Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, feel free to type in your questions at any time, but please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar, Experimental Treatments for Aggressive Pituitary Tumors, is being presented by Dr. Andrew Lin. Dr. Lin is a neuro-oncologist at Memorial Sloan Kettering Cancer Center and a member of the Multidisciplinary Pituitary and Skull-Based Tumor Center. In collaboration with his colleagues in endocrine, neurosurgery, and radiation oncology, he treats patients with aggressive pituitary tumors who are resistant to conventional treatments, i.e. surgery and radiation, with chemotherapy. Dr. Lin and the team at Memorial Sloan Kettering have published several research articles on pituitary tumors and opened several clinical trials. Dr. Lin, thank you so much for your involvement with the PNA's webinar program. There's going to be a brief delay as we change presenters.
Thank you for having me, Tammy. I'm Andrew Lin. I'm a neuro-oncologist here at Memorial Sloan Kettering. So today I'm going to talk about the management of aggressive pituitary adenomas. So I do have a few financial relationships to disclose. First of all, I do receive funding from Bristol Myers Squibb for a phase 2 trial investigating the use of ipilimumab and nivolumab in the treatment of aggressive pituitary tumors. I have also received funding from a company called Neotomics to investigate MGMT quantification via mass spectrometry and its applications in determining treatment response to chemotherapy called Temozolomide. So let me start by talking about the scope of the problem. So pituitary adenomas are actually extremely common. It's been reported that you would find a pituitary adenoma in about 20% of individuals that you took off the street if you image them on a modern MRI scanner. The vast majority of these tumors, which are often found by accident during the course of imaging for an unrelated reason, will require no treatment. Pituitary tumors typically only require treatment when they secrete hormones or grow at a rate where they cause problems by pressing on adjacent structures. When these tumors require treatment, they are often well controlled with conventional treatment, specifically surgery, medications that control hormonal oversecretion, and radiation for progressive tumors that are placing vision and other critical brain function at risk. It's only a small subset of these tumors that exhibit invasive behavior and invade the surrounding structures, and only an even smaller subset that behaves aggressively. It's these aggressive pituitary tumors that we're going to talk about today. So aggressive tumors can remain in the base of the skull but grow, causing local destruction and in that way significant disability. So the normal pituitary resides in this cavity here called the sella. So the tumors that arise from pituitary can grow upward, pressing on the optic nerves as they combine and enter the brain, causing vision loss. Alternatively, these tumors can grow into this structure here, which is called the cavernous sinus, where a lot of important nerves and blood vessels travel. When tumors enter here, they can cause double vision and a droopy eyelid. And these tumors, because they're close to lots of important adjacent structures, cannot be resected fully. Additionally, these tumors can grow very large and even impact the brain, namely the hypothalamus, which is up here, the temporal lobe, which is over here, and the brainstem. When the hypothalamus is affected by the tumor, it can cause behavior changes, including hypothalamic obesity as well as sleepiness. Invasion into the temporal lobe often provokes seizures, and involvement of the brainstem can have really quite severe symptoms because the brainstem is a relay station for much of the brain. In addition to being locally aggressive, aggressive tumors can also travel to distant sites, at which time they're called pituitary carcinomas. There's not much known about these pituitary tumors that spread because this is a pretty uncommon problem. While some authors have reported a very poor prognosis with an average survival of less than a year, we have seen very slow growing tumors that have traveled away from the original site. Pituitary tumors spread throughout the body in two ways. The first way is by entering the spinal fluid that bathes the brain and spinal cord, resulting in drop metastases like you see here. This is the spinal cord here. This is a spinal column. As you can see, there are little pituitary tumors that have entered the fluid and are now hanging on to the nerves leading the spinal cord. Alternatively, tumor cells can enter the bloodstream and then travel anywhere in the body. For example, in this patient's case, where it's traveled to the liver. Across cancer, generally malignancies that spread through the spinal fluid tend to do worse. Surprisingly, in pituitary carcinomas, this does not seem to be the case. It actually seems to be better to have metastases that are confined to the nervous system. Epidemiologic studies have not been performed to fully define the incidence and prevalence of this problem. With that caveat, one author estimates that there are around 200 cases of pituitary carcinoma in the US at any given time. However, the true number is unknown. So when does it make sense to screen for distant sites of disease? A patient with a progression of disease following radiation at that point has demonstrated aggressive behavior, and so I'd argue that surveillance for distant sites of tumor is warranted. So the standard PET scan tracks where sugar goes and is called an FDG PET. This scan is pretty useful for looking for distant sites of disease from pituitary tumors because these metastases typically show up quite well on this scan. The problem with FDG PET is that a high uptake of sugar is pretty nonspecific. Normal brain, as shown here, picks up a lot of sugar, and for that reason, it can mask an important finding. Another example of this lack of specificity is the uptake we saw in this patient's ovary. This uptake was thought to be just normal sugar consumption by the normal ovarian gland. Unfortunately, that did not turn out to be the case. This same patient underwent a different type of PET scan that used a different radiotracer called gallium dotatate. This radiotracer looks for cells with somatostatin receptors, which are only present in a few different types of cells other than cells that derive from the pituitary. This scan has a lot less background and is therefore a lot more specific. And for that reason, when this ovarian lesion also lit up with the gallium dotatate PET, we knew that this wasn't just normal uptake. This was actually a tumor that spread from the pituitary. For some patients, imaging of the MRI of the spine and also a lumbar puncture to look for tumor cells floating in the spinal fluid may also be indicated. Aggressive pituitary tumors, as they grow, can secrete more and more hormones, causing additional problems. Additionally, they tend to lose sensitivity to hormonal treatments, and so that is another problem that we often need to address in these patients. Specifically, for individuals whose tumors secrete ACTH, which promotes production of steroids by the adrenal glands, when the tumors are behaving aggressively, often surgical removal of the adrenal glands is required. Some people believe that doing these surgeries can drive tumor growth. However, because high levels of steroids are so toxic to patients, these procedures are often performed anyway. For patients with tumor secreting growth hormone, excessive production of growth hormone can also be very problematic for patient health and is also a major issue. For patients with aggressive tumors that remain confined to the base of the skull, the conventional approach for dealing with recurrent disease following surgery and initial course of radiation is more surgery and possibly a second course of radiation. It's well known that repeat surgeries place individuals with pituitary tumors at greater risk for problems like spinal fluid leakage, stroke, and diabetes insipidus, which is a problem where an individual cannot hold on to water. Moreover, these surgeries often do not result in a substantial removal of tumor due to frequent involvement of critical adjacent structures, like the cavernous sinus, which we discussed previously. A second course of radiation is often attempted. However, the optic chiasm and surrounding structures are often treated to the lifetime radiation limit after the first course of treatment. And for that reason, radiation places risk of complication. This is an example of the pitfalls of a second course of radiation. After this patient, JD's tumor progressed following an initial course of radiation, she was treated with a second course of radiation. Since the tumor touches her left optic nerve, there was no way to treat the tumor without sparing exposure of the optic nerve, which is highlighted here in blue. For that reason, it's not surprising that shortly after radiation was completed, she developed complete loss of vision out of the left eye. Evidence that it was the radiation that caused this blindness is seen here. As you can see, the optic nerve that transmits information from the left orbit to the brain is picking up the contrast. You know, this is clear evidence that the damage was caused by radiation. For this patient, adding insult to injury was the fact that after this patient lost vision, the tumor started growing anyway. Another problem that developed because the usual radiation limits were surpassed is that this patient developed a small area of radiation necrosis. So radiation necrosis is brain cell death caused by radiation exposure. The inflammation caused by radiation necrosis can plateau and then peter off. However, we have also seen instances where the inflammation persists and continues to get worse in a cascading fashion, resulting in life-threatening consequences. A similar process called osteoradionecrosis can also occur in the bone. Due to growth shortly after the second course of radiation, as you can see here, from here to here, the chemotherapy temozolomide was initiated. After treatment with temozolomide was started, improvement was seen in the tumor within 4 months, and also the cranial nerve abnormalities started to improve. This is a typical time course of benefit in patients that are treated with the chemotherapy temozolomide. When a response is seen, it typically occurs fast, after just a few months. In retrospect, if this patient had been treated with temozolomide instead of radiation, uh, uh, the expected result would be that her vision would have been saved. This is not to say that a second course of radiation is not sometimes the best option. Sometimes it is. Treatment very much needs to be individualized to the patient. So let's talk about temozolomide. Temozolomide is an oral alkylator chemotherapy that's primarily used in the treatment of glioblastoma and other primary brain tumors. There's no clinical trial evidence supporting its use in pituitary tumors. All the data supporting its use is retrospective. For that reason, this is considered an off-label treatment without an FDA approval, which means that it can be problematic getting this treatment covered by insurance. With that caveat, temozolomide is the only drug that can attack tumor cells with established effectiveness. Temozolomide is actually a fairly well-tolerated treatment. The main side effects of temozolomide are fatigue, constipation, and nausea. This nausea is generally pretty well controlled with pre-medication with anti-nausea pills. Additionally, temozolomide can sometimes cause rash, problems with lab work, specifically liver enzyme problems, low platelet counts, and low white counts, which can make it harder for an individual to fight off infection. Because the mechanism of action of temozolomide is that it causes DNA damage, people taking temozolomide cannot have children while on treatment. Additionally, there is a very small chance that temozolomide can cause infertility, and so sperm and egg banking is offered prior to treatment, with a caveat that infertility following temozolomide is considered pretty unlikely. After treatment with temozolomide, after being off the drug for a sufficient amount of time, many patients have gone on to have children. There is a small chance of developing a small malignancy, a secondary malignancy as a consequence of receiving temozolomide, specifically leukemia, but this is thought to be exceedingly rare, probably lower than the likelihood with radiation. The largest cohort in the literature supporting the use of temozolomide in the treatment of patients with pituitary tumors was from an electronic survey of the European Society of Endocrinology. This survey captured a total of 166 patients. In this large group of patients, an objective response was seen in 37% of patients receiving temozolomide. Specifically, a complete regression of the tumor was seen in 6%, and a greater than 30% shrinkage was seen in 31%. Of patients that responded, the response was maintained in 58%. That completed the course of temozolomide with a median time to tumor growth of 12 months following completion of treatment. Unfortunately, when people got this treatment, responded, and then were observed, when the tumor started growing and temozolomide was resumed, only 11% responded to a second course of treatment. This result is backed up by additional cohorts, and there are over 300 patients now in the literature supporting its use with similar results. If we could predict who would respond to temozolomide, that would be really helpful. Some people have looked into this and have focused in on a protein called MGMT. So MGMT is the enzyme that repairs the damage caused by temozolomide. Epigenetic regulation of MGMT, regulation of protein production at the DNA level, is an established marker for treatment response in glioblastoma, again, the main tumor that this chemotherapy is used to treat. In pituitary adenomas, it's been suggested that MGMT expression, as determined by direct investigation of protein production, is the better biomarker for response in pituitary tumor. In this work, low level of MGMT was correlated to a high rate of treatment response. Unfortunately, given that this data is retrospective and remains invalidated, the clinical utility of doing this type of testing is still unknown. Further study is required. There remain many controversies in the literature. It is unclear whether temozolomide should be used as a single agent by itself or in combination with other chemotherapies. There was a 4-patient case series a few years ago that showed a high response rate when temozolomide was used in combination with a second chemotherapy called capecitabine. Specifically, a complete or partial response was seen in 75% of patients getting this combination, recognizing the very small sample size. These 4 patients that received combination temozolomide and capecitabine all had low MGMT expression, and as per the prior slide, you would expect a high rate of response to temozolomide alone. For that reason, the benefit of adding the capecitabine is not completely clear, especially given that capecitabine is also chemotherapy, and the side effects of the 2 drugs are additive. With those caveats, this report is intriguing, and this does deserve further investigation. Another combination treatment that has been suggested is concurrent radiation and temozolomide. The European Society of Endocrinology report that we previously discussed did include a cohort of individuals that received combination radiation and temozolomide. This group of people had an objective response as defined as a complete or partial response in 71% of cases. There's no good benchmark data to compare this result, but this does seem to be a fairly high response rate, probably better than expected with radiation alone. In fact, there is a good biologic reason why one would think that the combination of radiation and temozolomide would be more effective than giving the 2 agents successively. Specifically, in preclinical models, in the test tube, temozolomide is a radiosensor that promotes tumor cell killing by radiation. It is not clear who might benefit from the addition of temozolomide to radiation, however. Radiation is thought to have a very high control rate all by itself, without the addition of temozolomide. In other words, for many people, radiation is enough. There are certain histologies that are associated with more aggressive behavior, such as Crook cell adenoma and sparsely granulated somatotrophs, which may be better candidates for the addition of temozolomide. Another reason to potentially consider adding temozolomide may be rapid growth and hormonal oversecretion. Radiation in general is less successful at hormonal control than controlling tumor growth. Typically, when patients benefit from temozolomide radiographically, there is corresponding benefit in terms of hormonal secretion. Adding temozolomide to radiation to promote hormonal control would therefore be a potential reason for pursuing this combination. Other questions that still need to be answered is the optimal time to consider temozolomide, the optimal treatment schedule, and the optimal duration of treatment. None of these issues have been evaluated in pituitary tumors, and so all treatment decisions at this point in regard to the use of temozolomide is based on extrapolation from the primary brain tumor studies. Most patients with receiving temozolomide receive it on a schedule where they get the drug for 5 consecutive days, followed by a 23-day break prior to starting the next monthly cycle. For patients that respond, treatment is typically continued for at least 6 months. There are other regimens that are sometimes used. However, this is less common. One alternative regimen is a low daily dose of the chemotherapy temozolomide. I mentioned previously that patients that initially respond to temozolomide don't generally respond to a second course. We may have answered the underlying reason for this. As discussed, temozolomide is an alkylator. As an alkylator, it causes DNA damage that then induces cell death, but only in the presence of a functional DNA repair system. Treatment with temozolomide can select for tumor cells with defective DNA repair. In a tumor cell with such a defect, treatment with temozolomide causes the accumulation of DNA damage, specifically C to T and G to A transitions, without causing cell death. In one of our patients with an ACTH secreting pituitary carcinoma, we investigated, and this is exactly how temozolomide resistance occurred. This patient developed an MSH6 mutation which inactivated DNA repair, which then resulted in the collection of over 5,000 mutations in a recurrent tumor that weren't present in her pre-treatment resection. As you can see, almost all of the new mutations were in base pairs that you would expect in base pairs that are affected by temozolomide. As expected, based on other people's prior experience in the development of DNA repair deficiency in our patient's hypermutated tumor, this patient did not respond to a second course of capecitabine and temozolomide. As you can see in this figure, this patient received capecitabine and temozolomide. Initially, the tumor volume decreased pretty dramatically. The patient was observed, and then when the tumor started growing again, the capecitabine and temozolomide was re-challenged. However, all her tumors started to grow in spite of this. This patient was treated to 2 other chemotherapies, carboplatin and etoposide, and really these other chemotherapies, which have been validated in neuroendocrine tumors that arise elsewhere in the body, there was no response. It was at this point that we considered trying immunotherapy. Specifically, we considered trying checkpoint inhibitors. Checkpoint inhibitors manipulate immune checkpoints which regulate the immune system and prevent tumor cells from eliciting an immune response. Ipilimumab specifically attacks CTLA-4, a molecule in immune cells, resulting in immune activation. Nivolumab blocks PD-1, which again releases a brake on the immune system. Because our patient with the ACTH secreting carcinoma had a high mutational burden, we suspected it would respond to immunotherapy, as it's been shown in melanoma that mutational load is associated with the degree of clinical benefit achieved with CTLA-4 and checkpoint inhibitors more generally. The theory is that mutations generate foreign-appearing proteins that the immune system can then react against. In this figure, there is a statistically significant improvement in overall survival in patients with a high mutational burden with melanoma compared to individuals with melanoma with a low mutational burden. There's also reason to think that pituitary tumors are uniquely susceptible to immunotherapy independent of alkylator-induced somatic hypermutation. In patients treated with ipilimumab for a non-pituitary neoplasm like melanoma or lung cancer, the rate of pituitary inflammation ranges from 4 to 15%. The molecule CTLA-4, which the immunotherapy ipilimumab targets, is supposed to be only on immune cells and not on normal tissues. The spleen and thymus is full of immune cells, and so there's expression of CTLA-4 in those organs. CTLA-4 expression was also found in the pituitary, but not found in the thyroid, nor was it found in any of the other tissue types tested. In this figure, they show that CTLA-4 antibodies like ipilimumab, when administered to mice, localized to prolactin and TSH secreting cells of the pituitary. It's hypothesized that this binding leads to the development of anti-pituitary antibodies, resulting in the high rates of pituitary inflammation seen when these drugs are administered to patients without pituitary tumors. Our patient with the ACTH secreting pituitary carcinoma received ipilimumab and nivolumab and ended up having a really dramatic response to this treatment. Within 6 months, the dominant liver metastasis reduced in volume by 92%, and the recurrent disease in her brain shrank by 59%. For the next year, the tumors continued to shrink. Based on this impressive response, we now have a protocol open that is accruing individuals, which is looking at the activity of ipilimumab and nivolumab in the treatment of aggressive pituitary tumors. The main inclusion criteria is progression of disease following surgery and radiation. For more details, please refer to the NIH website, clinicaltrials.gov. The identifier is NCT 040-42753. Besides temozolomide, there are 2 treatments that have undergone further studies than most treatments proposed. The first treatment is the oral tyrosine kinase inhibitor lapatinib, which has been investigated in prolactinomas, pituitary tumors that secrete the hormone prolactin. The second treatment is peptide receptor radionuclide therapy. Lapatinib was investigated on a clinical trial based on the finding that EGFR and ERB2 may be driving this tumor type. And these 2 targets are acted on by the drug lapatinib. At the last Endocrine Society meeting, it was reported that on this trial, of the 6 patients enrolled thus far, 3 achieved stable disease, 1 patient had a minor radiographic response, and 2 progressed. The investigators looked to see if they could identify the molecular reason why that 1 person responded, whereas the others didn't, without success. The other treatment that I mentioned is peptide receptor radionuclide therapy. This treatment uses a protein fragment that binds to a receptor that's found on pituitary cells. This protein fragment has a radioisotope attached to it, for example, lutetium-177. In this way, peptide receptor radionuclide therapy is the mechanism by which radiation can be delivered to pituitary tumor cells, perhaps with less collateral damage. One review of the literature identified 4 responses using this strategy. This review looked at multiple peptide receptor radionucleotides and remains very investigational. There are other targeted treatments that are potentially promising candidates for further investigation, some of which have ongoing clinical trial. There is interest in treating patients with prolactinomas with everolimus due to a case report of a patient who had a decrease in prolactin levels and modest radiographic response when challenged with this drug. There's also a clinical trial in China looking at gefitinib, another EGFR inhibitor, in the treatment of patients with Cushing. The rationale behind this is the identification of recurrent mutations in the USP8 gene that results in enhanced EGFR signaling in a subset of ACTH secreting tumors. One of the other ongoing trials that we're aware of is a trial looking at the drug saliciclib, which is a small molecule for which there's preclinical data that it can result in biochemical responses in ACTH secreting tumors. Aggressive pituitary adenomas are an understudied problem. This is for multiple different reasons. As explained, a basic understanding of how common this problem is, both in the United States and around the world, is lacking, as this problem is not appropriately tracked, unlike many other malignancies. Because these tumors are relatively uncommon, there are only a couple of patients that are in need of a clinical trial, even at the largest pituitary tumor center. And for that reason, these trials need to be multi-center. Unfortunately, there are no clinical trial consortiums, unlike other orphan cancers, to facilitate these multi-center efforts. Moreover, because relatively few patients need these treatments, there's a fairly limited interest among drug companies to pursue treatments for this disease type. Clinical trials are extremely expensive, especially clinical trials that are multi-center, and so they often cannot be performed without drug company support. Patient advocacy groups like the Pituitary Network Association are therefore essential for creating awareness of this problem and advocating for better treatment so that the basic work that needs to be done will be done. All right, I'm going to break now. Does anyone have any questions?
That was excellent, thank you. There are a few questions here. Would a papillary craniopharyngioma be considered an aggressive pituitary tumor?
No, craniopharyngiomas are actually a completely different tumor type. Craniopharyngiomas actually do not arise from the pituitary gland. And so the treatment is completely separate. Although, you know, the complications of craniopharyngiomas due to their similar location are very similar.
Okay, thank you. In your trial, will you accept a patient like myself with a possible benign pituitary tumor that is wrapped around my optic nerve and carotid artery? This is my second tumor in 2 years and third in 6 years of surgery. My tumor is ACTH producing.
So the clinical trial that we have open does require prior treatment with radiation. The reason that this is a requirement for the trial is that radiation is actually in general very capable of controlling tumors. It's only a small subset of people that have tumor growth in spite of radiation. You know, ipilimumab and nivolumab can be well tolerated. However, they do have the potential for causing significant side effects. You know, any clinical trial is trying to assess for benefit where benefit is unknown. Given that your tumor potentially could be well controlled with radiation, we wouldn't want to subject you to the added risk of getting ipilimumab and nivolumab if your tumor could be well controlled with radiation by itself.
Okay, thank you. Are there any trials for temozolomide being considered for pituitary tumors?
So in the literature, all that's available are retrospective reports. So basically what that means is people have looked into their databases and written up how their patients did when they got temozolomide. No one has done a clinical trial. You know, the only clinical trial that I'm aware of that is currently looking at temozolomide is a clinical trial that is being performed at Weill Cornell by Rajiv Maggi. It's looking actually at combination treatment with temozolomide and capecitabine, not temozolomide alone.
Okay, great. Hello, I'm performing an in vivo treatment with Kettering in prolactinoma xenografts. What would you recommend to me based on your experience about treatment cycles, doses, and duration to make the treatment more effective?
Capecitabine and temozolomide was tried in pituitary tumors because it showed activity in neuroendocrine tumors outside of the central nervous system. My understanding is that the researcher that came up with this combination treatment had preclinical evidence that temozolomide and capecitabine work synergistically together, and he had a reason for recommending the current treatment schedule that's used, which is capecitabine for 2 weeks, and then temozolomide is given for 5 days out of those 2 weeks.
Okay, thank you. The previous question about the tumor that was ACTH producing has added on. You're suggesting radiation for me, but it could cause blindness, which I don't want. How can one avoid blindness with radiation to the optic nerve?
Yes, well, so the optic nerve. So I'm not a radiation oncologist, and so I think that this should be something you discuss in more depth with your radiation oncologist. I mean, so the optic nerves can be safely radiated to a known amount. For most people with large pituitary tumors, their optic nerves will be radiated on the first go round, and generally that's safe because because the radiation oncologist will keep the radiation below the known limit that the nerve can receive. For most patients who get radiation, the risk of blindness due to the first course of radiation is very low.
Okay, thank you. Is this chemo available for benign pituitary tumor cells? 3 previous resections plus radiation, GH and IGF-1 are climbing on Sumavert.
Yes. Yes, it seems that the fact that your hormones are rising could mean that the tumor is growing and that you will therefore need another treatment to control further growth to prevent problems down the road. Um, in the absence of tumor growth on imaging, if your hormones are well controlled, it may be that you do not need further treatments like temozolomide or this clinical trial. This is something to be discussed with your endocrinologist.
Thank you. I have had 2 surgeries and gamma knife radiation. At this point, the tumor is reducing. Earlier in the presentation, you stated that there is an area in the pituitary section of the brain that causes fatigue. Was that in the sinus? And it's a non-secreting benign tumor.
Sorry, please repeat the question. So after gamma knife,
2 surgeries and gamma knife, the tumor is reducing. Early in the presentation, you stated there is an area in the pituitary section of the brain that causes fatigue. Was that in the sinus?
Yeah. So fatigue after radiation is a very common side effect. Usually, people that are more fatigued after radiation, the fatigue subsides. In I am a neuro-oncologist, not an endocrinologist, and so uh, I'm not an expert on this issue. However, I can tell you that once you've gotten radiation to the pituitary gland, hormonal function can be affected, and it's possible that the increase in fatigue is due to a decline in hormonal function due to the gland. I mentioned earlier that aggressive tumors, when they grow really large, that they can press on a structure of the brain called the hypothalamus, and that can lead to a lot of sleepiness. I mean, this is actually a pretty extraordinary. It's a pretty extraordinary situation when pituitary tumors grow that big and press on the hypothalamus. Before a pituitary tumor would press on the hypothalamus, it would have to go through the optic nerves, and so there would be significant vision loss and other issues. For most people with fatigue after radiation, this is not the reason for the fatigue.
Okay, thank you. The previous questions about doses and durations, treatment cycles, has added on to her question, and she asked, do you suggest the double daily dose of TMZ or just the single one?
So I'm not completely clear what you're asking. So the most standard temozolomide regimen is uh, uh, 5 consecutive days of temozolomide followed by a 23-day break, and then you start up the temozolomide again, 5 days on, 23 days off. There are alternative regimens that have been used for primary brain tumors that are sometimes also used for pituitary tumors. There's the low dose daily dosing, which is either 50 or 75 milligrams per meter squared every day continuously. I mean, when you do this dose, when you take the low dose every single day, it does actually turn out to be more chemotherapy than you administer if it's 5 days on, 23 days off. Nevertheless, for some people, a lower dose given every day is better tolerated. It can have less side effects. It can potentially have less effects on blood counts. In terms of effectiveness, there's no way of knowing which is better in pituitary tumors. I think from my standpoint, the main reason to do the low dose daily dosing is to help with side effects. But it's certainly not wrong to be on the low dose daily dose because there's never been a head-to-head comparison.
Okay, thank you. I've heard that radiation to the brain can cause pituitary to stop producing hormone, leading to oral hormonal therapy. I've also heard radiation can cause dementia. Is this true? And I've heard that radiation in 10 to 15 years, a malignant brain tumor. And what are the chances of an aggressive pituitary tumor responding permanently to radiation? If it won't work, I'm hesitant to use it with all of the potential consequences.
Right. To answer the question, I do need to know what is being radiated. So any radiation that includes the pituitary gland does have a fairly high risk of causing pituitary dysfunction down the road. Fortunately for pituitary tumors, sorry, fortunately for the pituitary, all of the functions, when the function is lost, the hormones can be replaced, and so a problem with pituitary function is not as debilitating as problems elsewhere. So, for most people getting radiation to the pituitary, there's relatively little exposure to the brain, and so you would not expect a whole lot of neurocognitive effects unless the tumor is extremely big. And for that reason, the radiation port has to be a lot bigger than usual. I mean, there are some new radiation techniques that potentially can limit exposure to adjacent structures, such as the temporal lobe, hypothalamus, brainstem. So protons have now become very mainstream in the use of in the treatment of pituitary tumors for that reason. The radiation administered by protons is really no different from the energy administered by protons is no different from the energy administered by normal photon radiation. Where the two types of radiation differ is that with protons, where the beam goes can be much better controlled than oftentimes with photons. In terms of long-term control rates, for the vast majority of people, radiation will be an effective treatment. As I'm a radiation oncologist, I don't have the numbers off of the top of my head, but the long-term control rate of pituitary tumors with radiation is high. And I think part of the question is, what's the risk of secondary malignancies? Well, your radiation oncologist will quote that, but it's generally thought to be quite low.
Okay, thank you. So I don't see any more questions. So anybody who has any questions, get them in now. A couple of comments. Thank you for your research in this area. It is so important to those of us who are trying to live with this diagnosis. And another thank you very much. And I don't see any more questions, so I think we'll end it here. Dr. Lin, thank you for taking the time out and presenting this valuable information. This concludes today's webinar presentation. We appreciate you taking the time to join us. If you missed any part of this webinar, or if you would like to share it with family members or friends, it'll be available on our website, www.pituitary.org, after it is edited. There will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. Thank you for joining us, and everybody enjoy the rest of your day. And again, Dr. Lin, thank you so much. Have a great day.